ONtheGo podcast.
Is PRP the solution to our future problems? Team physician for the Chicago Bulls, White Sox and Fire, Dr. Jorge Chahla from Rush University Medical Center, and Dr. Jari Dahmen, Amsterdam University Medical Center's University of Amsterdam, discuss the potential of PRP in 2040. My name is Takao Shima, and this is On The Go, the podcast all around orthoregeneration.
We're happy to introduce Jorge Chahla, MD, PhD, working in Chicago, and very excited to have you on the podcast for the On The Go podcast. And we'll be talking about PRP in 2040. But before we start off, we'd like to get to know you a bit better. And we ask you the question because I think it's still either end of the morning or beginning of the afternoon there, with how do you drink your coffee?
Well, I like espresso and I like lattes. So I like a latte with 2 or 3 shots of espresso in the morning. And then I also drink mate, which is an Argentinian drink that we actually prepare in a little cup that has kind of like a type of tea that we drink out of a straw.
Yeah, I've seen that one with a lot of soccer or football players from Argentina, and I think also from Argentina, Uruguay. Yeah.
Yeah.
So that's good. So and how many times a day do you drink your mate? Is it only in the afternoon, or when is that?
Usually throughout the morning and sometimes in the afternoon as well. It's kind of like a social thing too, so it's actually kind of fun.
And you bring it to work, the bag with all the essentials?
I bring it sometimes. My PA has it now, and I have a couple of Argentinian fellows now that actually do it for us, which is great.
Nice. That sounds great. And what is your favorite place then at work or outside of work to drink your coffee or to drink your mate?
I love being home with the kids, and sometimes going to the parks and just having fun outside. Here in Chicago, you can't do that for 12 months, maybe 7 or 8 months. You can get out and enjoy the outside. So we try to do that as much as we can.
Okay, great. Well, at least with most of the ones that we interviewed, they all drink coffee. So you're the first one to drink mate. So that's great to hear. So let's head off and take the airplane to 2040, with our topic being PRP in the year of 2040. Being or questioning, is that the solution to our future problems? And before we can get into that, I would like to ask you to share your understanding of what PRP is and how it may work.
So platelet-rich plasma is something that it's been around for over 50 years. It's something that dentists have shown us, they used to inject it way before we discovered it. And it's one of what we call autologous blood products. And, they have been shown in over 30 clinical trials now to be better, at least for function and symptoms, when you treat, for example, the symptoms of osteoarthritis or early osteoarthritis and lateral elbow epicondylitis. So that's, I think, the majority of the literature shows that at this point. The definition of PRP, it's still up for grabs, I would say. Some people say that it's over 1 million platelets. Some others say that it's an increase of over 5 times the baseline of platelets. But what we know now is that there are some studies. I did one with Rob LaPrade when we tried to heal MCLs of rabbits, and then we did histological analysis and biomechanical analysis, and we found that those rabbits that had the PRP that were more concentrated, so 4 times the baseline, had worse outcomes than the ones that had it 2 times or just 1 time. Martha Murray also, in an ACL repair model, did something similar with baseline, blood and platelets and 5 times the amount of platelets, and she showed detrimental effects of having too much platelets. So the first thing is that we don't know what it should be, right? Is platelet-rich plasma or too much platelets, is that a good thing? And if it is, how much is too good or how much is not? The second thing is that we don't take into consideration other things such as growth factors, red blood cells, white blood cells. So sometimes we know from a hemophilic literature that having too much red blood cells is not good. We know that injecting too many white blood cells is also going to create a lot of inflammation within the joint. So I think we need to evolve a little bit more to saying, if you have arthritis, PRP for you should be something that has this amount of platelets, this amount of red blood cells, white blood cells. It should not have any VEGF, which can cause more fibrocartilage. It should have a lot of TGF beta, which can help with with cartilage formation and so forth. So I think, as we talk about where do I envision PRP to be in 30 years from now or 20 years from now, I think it will be much more customized to what we're trying to treat. And in order to do so, I think we need to understand better, what are we treating? Somebody that has arthritis on X-ray may come from an inflammatory inflammatory issue, a degenerative issue that may be completely different, right? So I think we need to understand first, what are we treating? And then I think we can tailor or customize our PRP or autologous blood product much, much better.
All right. Well, that's a very comprehensive explanation for what it is and what it is used for. And in your clinical practice and your daily practice, for which indications do you use it, and what is the scientific background or evidence behind those indications?
So, as I discussed before, we try not to use it as a first line of treatment in our practice for non-professional athletes because it's an out-of-pocket expense here in the States.
Mm-hmm.
So, it's hard for a patient to pay out of pocket for other options that may not be out of pocket and maybe just as effective, at least in the short term. So what I usually do, for example, for arthritis is I treat patients with physical therapy, anti-inflammatories. Most people actually respond to that. If they come back with pain, then we try a cortisone injection to try to see if we can ameliorate the symptoms. And if that works but is not durable, then we offer biological injections. And we use a combination of HA with PRP if we're able, because we've seen that there's a synergistic effect of using both together.
Mm-hmm.
The outcomes of PRP injections have been shown to be very beneficial for mainly two indications, which are lateral elbow epicondylitis, as well as the symptomatic treatment of early to moderate arthritis. That's where we have most of our evidence. I was lucky enough to be part of the clinical practice guidelines from AAOS, and we found that there were several studies that, although not hugely powered, show that PRP can be beneficial in regards to pain, right, and symptoms. There's some other and newer studies from JAMA where they show that there may be no difference when compared to placebo. But we also know that that placebo, which is maybe saving sometimes, is not a great placebo, just because it can affect the joint pH and other things inside the joint to the point that they can create actually a therapeutic effect. But I think we need to continue to do more studies that are rigorously designed, and they have enough people that can show us actually a real difference if there exists. But as of now, when we have done and published a couple of systematic reviews and meta-analysis, what we can see is that the size effect of PRP at 1 year is significantly better than that one of the gel, cortisone, of course, the placebo.
Okay. I think that perfectly brings us to a follow-up question on that, because you also mentioned the JAMA studies on the placebo injections. I was wondering, why do you think that this effect could have happened in that sense, that comparative effect of being maybe no effect at all, or a little effect, or non-significant results? You mentioned a little bit on that as well, being the change of the pH. And a follow-up question on that is, what should we do in the next 17 years to go to 2040 to really understand the real effect of PRP and to develop or understand some studies that are going to find out for whom it works and for whom it doesn't?
I think that's the holy grail, right? Like that's the key question. And arthritis, for example, has such a massive amount of confounding factors, right? Such as alignment, status of the meniscus, BMI, status of the cartilage. The Cardinal Lawrence classification, it was a good classification for X-rays and potentially for joint replacement, but it doesn't give you specific details as to the health of the cartilage. We usually make decisions based on mechanical factors such as mechanical axis, arthritis, and so forth, but we rarely make decisions on inflammatory factors or some of the joint milieu, right, like the joint synovial fluid. And I think in order to progress, that's what we need to do. We need to understand exactly what we're treating, so that we can take and make our treatments much more targeted towards what we want to treat. I do think that there's several things that we do that create a therapeutic effect. One of those is injecting saline into the joint, right? We've seen that changes the milieu of the synovial fluid to the point that it can actually exert an effect. To the previous 2 points, I think the only way that we can find a better answer is to do a better study. And the problem with this is that this based on all the confounding factors that we have, in order to be sufficiently powered, we need to have a massive amount of patients enroll in the study, and of course blinded, and trying to target a very specific subgroup of people, right? We might say it's a Kennedy-Lawrence 2 on X-ray that have a normal alignment, that have no significant meniscal pathology, or that has this or that pathology that excludes root tears or radial tears, and try to make it as comprehensive as we can and as targeted as we can, and have as many people as we can to try to understand what the real effect is. Most of the randomized clinical trials, which I think have helped understand some of this, have shown a benefit towards PRP. But again, the risk of bias when you look at those specific subjects and so forth is high. So although there is some evidence, and there's better evidence for PRP than there is for a lot of other sports medicine or orthopedic things that we do, I still think that there's a lot of room for improvement in order to get us better data to help our patients make the best decisions.
So if I understand you correctly, we might want to evolve beyond the RCT and maybe go into a large prospective cohort or a large database study following multiple thousands of patients with different indications, and then trying to filter out for whom it might work and for whom it might not work. Is that something that you're targeting with your answer?
Two things. I think we should do both. If we can have a larger RCT, that's the highest quality of evidence that we can get. But again, it's fairly expensive. It's usually not sponsored by any companies, right? Because they don't have a lot of skin in the game. So it's hard sometimes for a single institution to launch a study like that. We're currently doing one on BMAC against cortisone, and it's not as easy to recruit patients, and there's a lot of costs associated with that makes it difficult to run. Doing a multi-center study that I think will be extremely beneficial will be difficult, but I think it's not impossible. And societies and professional societies and things like OntheGeneration Network and ON have been extremely generous about providing funds for data that can provide further answers to our questions. So I think that's the way to go. And I think creating a registry with a repository, as you discussed before, I think it's another great way to understand both how outcomes in regards to PRO change, but also in the synovial milieu. Mm-hmm. So if those things change after the injection, I think it's a game changer, because we know that sometimes the degenerative changes are linked to what happens with the intra-articular milieu.
And how do you think we would be able to measure the synovial milieu? How do you think that would be possible? It's quite something that's untangible, right?
Yeah. So there's multiple things you can do. There's an association here. It's called the Biologics Association that pretty much planned this study, which is having not only a PRO system between multiple institutions, but also having a repository that would sit potentially at the Mayo Clinic, where you would take a synovial sample, let's say before you do the PRP injection, and then you would do it at 3 months, 6 months, and 12 months, and analyze that with multiplex analysis, where you'll be able to see, how much interleukin-1/6 you have, telling you that there's a lot of inflammation, or how much CTX2, which is a product of degradation of cartilage. And based on what you see, you can actually analyze and see where that joint is going to, if the degenerative process has diminished, if the inflammatory process is better than it was before, if it's still the same, and how do we, adjust and move forward based on what we see.
And do you think such an approach will yield results that will be able to develop an individualized, maybe biological or PRP approach in 2040, where we can really target for that specific patient?
Absolutely. My dream would be like having something like a strip that diabetics use, for example, right, where you actually can measure exactly how much sugar there is and things of that nature, I think will evolve to something more of understanding what's the actual diagnosis of that knee, right? Because sometimes an X-ray cannot tell you the whole story. So if we have kind of like a strip band or something of that nature that we can measure TGF beta and interleukins and VGF, we may have a better idea as to how to treat it and how to customize the treatment much better. I think that will make the treatment much more effective.
And I think that also brings us to a study that you published in 2019 with Dr. Cole in arthroscopy, in which you send out the message that PRP may be of use in the early stages of OA, before the patients may present with symptoms. And although that was published in 2019, I think it could be of relevance for the future. Could you maybe share some insights into how you think the road towards this approach will look like, and how the actual clinical application will be for this specific citation in 2040?
So in the clinical setting, we do not use PRP prophylactically. And the reason being is that I don't think there's enough evidence to suggest that prophylactically treating an asymptomatic knee yields a better outcome in the future. That being said, I think it's a potential avenue for treatment, right? If we understand that, for example, having a high level of interleukins or MMPs within the joint is detrimental for the joint, and that can accelerate the degradation. There's some really good studies with Christian Latterman, in an ACL model, the post-traumatic arthritis model, where he has shown that injecting cortisone injection, for example, at the time of the trauma and potentially at the time of surgery, which is a second increase in all these molecules, can help those molecules not be as inflamed or not be as high in the postoperative period. That may be something that we do, right? Not only for primary osteoarthritis, but potentially for traumatic arthritis. Let's say if you have an ACL, maybe a PRP injection can yield the same result and potentially avoid the downstream of, catabolic, things that happen of the knee once you've had an intra-articular injury. So I think there's a role. I think just the thing that we don't know enough as of now. I think Christian Latterman's work is, putting some light into some dark areas that we've had in the past. And I think that's something that we should follow very closely.
Yeah, and I think that also brings it towards the thought of that OA, or at least a post-traumatic injury, is part of like a cascade or a process that goes downstream, as you just mentioned. Then referring back to that study that you published in 2019, I was wondering how what you think the option would be, or the solution will be, to really find or identify those patients that are early in the downstream, in order to target them at an early phase so that they do not move more downstream. And how do we find those patients? How do we know who those are?
I think, there's a couple of indications that I think are way easier to find, right? And we know will develop arthritis fast. And those are people that have intra-articular fractures, people that have root radial tears, people that have had ligamentous injuries intra-articularly. And then, we know that those people have a higher tendency to move into arthritis. When you look at data that has been published, there's almost a 50% chance that you will have arthritis after an ACL, even reconstruction, at 15 to 20 years. So we know that those people will develop arthritis. So those are the groups that we may potentially want to intervene to try to see if the intervention can yield a disease-modifying drug, right? Which is what we've been trying to find. We usually just treat the symptoms, but we have not found a disease-modifying drug that can help us modify that curve of decline. And I think targeting some of those injuries that we know will accelerate that process is potentially the best first step.
Now, so what do you think will be different for you as a clinician or as a surgeon in 2040 when treating the musculoskeletal injuries with PRP? How would the practice be different from in comparison to now?
I think that there's two things that will change. One is that we'll have a more accurate diagnostic tool that will allow us to really understand what's going on. And hopefully we have some normative data that shows us, a normal knee should look like this. And this is how this is deviated from normal. And I think that will allow us to have not only PRP, because PRP is it's like a shotgun approach, right? We have a million growth factors, a million things that get freed up, and we really don't know exactly what actually causes the benefit or not. So I think in 20 or 30 years from now, the key would be to really identify what the problem is and maybe just target it based on a couple of molecules. Let's say if you have a lot of interleukin, where you can just inject interleukin-1 receptor antagonist, right?
Mm-hmm.
So very, very focused on what you have. And I don't think it's going to be this shotgun approach that we're doing right now, but I think it's a good start. We just need to understand what's going on first and then how to really target that problem.
So you imagine your clinic being starting with the patient coming in, and then you could be adjusting or applying like a diabetic strip, but then for the joints in an outpatient setting, and then we'll be going back into the lab to analyze what can be read on that strip. And based on that, the patient comes back maybe in a couple of weeks with a very personalized, maybe even a genetic cocktail of an injection into the joint. Is that something that would be?
Absolutely. I love that. I think we're far, but I think that's what we should go to.
Very nice. Very nice. So that's I think that gives the listeners a lot of insights already in your brain for 2040. We'll shift a bit towards Argentina. We've already spoken about mate a bit before, and I know our listeners are interested into orthoregeneration, but we also want to know your background and where you came from and how you became successful and a leader in this field of orthoregeneration. Could you tell us a little bit about how your journey was from being a child onwards into growing up into Argentina to becoming a renowned surgeon in Chicago? How did that happen?
So my dad is an orthopedic surgeon as well. So I always had it in my mind as I was going with him, to the hospital on weekends and rounding on patients that, I like that. I like the interaction. I like the possibility of getting somebody better to, what they love to do and things of that nature. It sounds cliche, but it's really, a humbling and beautiful experience to be able to bring somebody back to what they love to do. And then I always practiced rugby, and I've seen all the injuries that you can imagine, from shoulder dislocations to multi-ligament injuries and even a hip dislocation in the games. And, just trying to think that I could help those people actually encouraged me to actually follow that path. And then I did medical school in my hometown in Tucumán in the north of the country, which is the smallest province in Argentina. And then did residency with a PhD program in the British Hospital of Buenos Aires. And then in the Universidad Católica Argentina is where I completed my PhD program. And then I came to, at the last year of residency, we have an opportunity to come to the States or anywhere and spend 3 months with whomever we want to. And I knew I wanted to do sports. So I came to HSS first, and then I went to rotate with Dr. Rob Laprade in Vail, Colorado. And absolutely loved the experience. I always loved research, and unfortunately in Argentina it's a little bit more difficult to perform research and to do research because there's not as many resources as we have here. But I had absolutely phenomenal mentors in Argentina that pushed me to be my best. And when I came here, we had a great relationship with Rob, and Rob told me you should probably stay, and ended up giving all the steps and ended up staying and doing multiple fellowships there at the Stemman Clinic then, in LA and Colonel Joe and Cedars-Sinai Institute with Dr. Mandelbaum and others there, which was a great experience as well, and a great, orthoregenerative experience. And then finally here at Rush, where I stayed on staff. But, it's been an absolutely phenomenal, experience. Everybody that I encountered was incredibly generous with their knowledge. And, I think it's a matter of finding the right mentors, and I've had great people along the way, co-residents, co-fellows that have helped me, improve in my skills and try to be the best that I could be. So I'm very humbled and very, very honored to have shared the way and the path with such great people. I can't complain, not even for a bit.
And that's very great to hear hear your story from where it started and where you're at now. And I think reading through your answer is also related to my next question, being to share some secrets and tips in your approach and way of working into how you got successful and your keys to successes. That I heard that you had great mentors. Could you maybe share some other tips and secrets in your approach and in your way of working, in your way of thinking, of being here and being successful both academically and clinically?
I think, it all surrounds just one word, which is attitude. Right? You want to be the best that you can and take every opportunity that you have and make it the best. If somebody gives you an opportunity to write a paper, then do it fast, do it good, and just show them that you care. And I think that's the most important thing. Clearly, if you go to a surgery and you're in the back of the room just texting your friends or, on social media, nobody will give you anything. But if you're there, you're engaged, you're filming the case, you say, well, let's publish this paper, let's take pictures. What do you think about this or that? And you show mentors that you're engaged, they're more willing to give you more. And the more you ask and the more you try to do, the more they will give you. So it's kind of like a positive feedback or engagement with them, to the point that you show them that you can actually provide some value by doing things that they don't have time to do. And they see the value in you of being mentor or being your mentoree. And I think that can certainly propulse your career several years forward, because there's no way that you can do those things on your own. And you start creating these relationships that are invaluable, right? I can talk to my mentors almost on a daily basis, and I just can't stop learning from them, because there's things to learn every single day. And sometimes you think that you know something relatively well, and something happens clinically to the point you say, well, I had that blind spot that I didn't know about. And then you call your mentors, you watch another video of their surgeries, and then you learn another trick and things that you haven't seen before. So I think it's just a continuous learning experience. It's important to stay humble and nimble. Change.
That's some great tips out there that we can use on a daily basis, I think. Regarding maybe specifically research projects in the orthoregenerative world, give us a little bit of an insight into your brain, into how you get your inspiration for new projects. How, what is your innovation? What is your inspiration? Where do you get it from? New ideas.
I think research gives you more ideas. Every time you do a research project, you end up with more questions. And every time you go to a meeting and you hear somebody say something new, then that sparks your interest in something new. You say, well, that's interesting. And sometimes you may go to a meeting that has nothing to do with what you do, which is also interesting, because sometimes you get ideas that you can extrapolate. And you can extrapolate from other joints as well. And we're doing a synovial study now that one of my partners, Adam Yankee, did here for the knee. And we're doing this on the hip. So sometimes just cross-linking and talking to other colleagues throughout the world that may have other ideas or other avenues of thinking, it's actually very, very important to move the field forward. And always be encouraged. Sometimes the results are not what you're expecting to see, and sometimes you'll find people that say, well, that nothing works, and this is just all on, it's not true, and I don't believe in this. And it's something that will happen, and I think we all need to fight, because even though the data is not perfect, I think the only way to move the field forward is by doing something. I think if we just sit in our living rooms and just say that nothing works, it's not going to get us anywhere.
I totally agree with that. And my mentor always says, if you answer one research question, you will maybe close one door, but then while closing one door, you will see 20 more doors, and you have to pick which one you want to pick to be able to move forward. So I think that also suits your thought on that. Moving towards the end of the podcast, we have some last questions that are always maybe a bit of a surprise for our guests, to get to know you even better. What is your guilty pleasure, Jorge?
I love, two things. One is I love music. So I spend a lot of time in my house. We have like a music room, playing guitar and drums. And, I love coffee as well. So we've been having classes with a barista trying to teach us some secrets of how to actually, grind the coffee, how to set it up so that you have a good throw. And, it's been really fun. I love
to make little hearts into the cream.
Yes.
Nice, nice. And what is one thing that most people don't know about you that is special?
I think that, a lot of people think I'm very serious, and actually not at all. So sometimes when you have people come and rotate with us for a month, they're very hesitant to approach, and we actually have a lot of fun here in clinic. And as soon as they see that it's kind of like a friendship approach more than a mentor approach, it's much more fun, and they relax, and it's actually a great experience to get to know people from all over the world that come here to Rush.
Awesome, great to hear. And then your last one, if you wouldn't have become a researcher or clinician, what would you have become? You can't say a professional rugby player.
That was one of my instincts. I knew it was not as good. I would have loved to be a rock star, but also my skill set's not hard to be able to become one. But I would have loved to be a rock star.
All right, that's a great way to end it. Thank you very much for picking your brain on the future of PRP in 2040, and on talking about Argentina and your guilty pleasures. And we hope to see more of you in the orthoregenerative world.
Thank you very much.
Thanks so much.
On the podcast, it's phenomenal.
Finding the right mentors and show that you care is valuable advice from Jorge Chahla. Stay tuned for more content at my.on-foundation.org. Thank you for listening and have a great day.